Yanımızda derneğimizin başkanı Profesör Doktor Başar Cander var. Kursumuzla ilgili düşüncelerinizi alabilir miyiz hocam?
Efendim Sono School bu 3. yılına girdi herhalde International alanda. Çok güzel işler yapıyor. Şimdi öncelikle şunu söylememiz lazım. Sonografi, ileri sonografinin acil tıp dünyasındaki yeri giderek farklı bir konuma geliyor. Yani hani hep klasikleşti, stetoskop diyoruz ama daha da ötesi olacak. Bazı müdahaleleri bunlar olmadan yapamayacak hale geleceğiz. Dolayısıyla bu ultrason kullanımı çok önemli. Ama Sono School buna başka bir şey kattı. Gerçekten bu ülkemizde yaptığımız gelişimi yabancı ülkelere taşımamız ve orada liderlik yapmamız Sono School'un başka bir özelliği olarak gündemde. Tabii EPAD zaten böyle bir misyon edinmiş durumda. Yani acil tıp ihracatı yapıyoruz. Buna Sono School'u eklemiş olduk. Türkiye'den başlayan bu hareketi 6 ülkeye yaymış durumdayız. Bu ülkelerde bu eğitimlerin yapılması çok önemli. Çünkü biz acil tıpta öndeyiz. Eğer biz onları beklersek ilerleme yavaş olur. Biz onları çekmeliyiz. Bu konuda uluslararası partnerlerimizle birlikte çok iyi işler yapıyoruz. Dolayısıyla Sono School çok önemli bir marka bizim için. Aciltv'in çok önemli bir markası. Tabii şimdi amatör manada bu kurslar birçok yerde veriliyor. Ama şimdi kursa katılan herkes, özellikle İngilizce olan bu kursun, uluslararası bir dille olan bu kursun farkını hep bize ifade ediyorlar. Eğitmenlerimiz çok farklı, çok yetenekli. Yayın aşamasında çok farklı pozisyondalar. Bunun üzerine bir de yani kursun kalitesi diğer kurslarla kıyaslanmayacak şekilde. Bu yüzden de zaten açar açmaz doluyor. Bunda yıllarca emek veren hocalarımızın çok önemli katkıları var. Başta Sono School Başkanı Erol Ünlüer ve siz değerli hocamızın liderliğinde bu iş gayet iyi ilerliyor, ileriye gidiyor.
Sayın hocam, ben de Sono School takımı adına her zaman desteğinizi hissetmekten çok mutluyum. Desteğiniz için, yardımlarınız için, bize liderliğiniz için çok teşekkür ederim.
Ben teşekkür ederim, sağ olun.
Evet, yanımızda Çanakkale 18 Mart Üniversitesi Tıp Fakültesi Acil Tıp Anabilim Dalı'ndan doktor öğretim üyesi Doktor Canan Hanım var. Hoş geldiniz kursumuza. Kursla ilgili düşüncelerinizi öğrenebilir miyiz?
Çok güzel, çok memnunum burada olmaktan. Daha önce bir kongre vardı. Türkiye Acil Tıp Derneği, ATÜDER'in ve USM'in beraber düzenlediği. Orada ben Erol Hoca'yı görmüştüm. İlk orada haberim oldu böyle bir kurstan. İngilizce olması ilgimi çekti. 40 kişiyle sınırlıydı. Ve çok önceden paramı yatırdım. Oradan haberdar olmuştum. Bugün de işleyiş her şeyden çok memnunum. İngilizce olması çok güzel. Pratikler güzel. Mutluyum yani. Zaten ultrason yapıyoruz. Ama üzerine ek bilgi katmak çok güzel oldu. Erol Hoca'dan öğrenmek de farklı bir ayrıcalık. Erol Hoca ile İstanbul'da da biz beraber karşılaşmıştık, çalışmıştık. Bir toplantıda da beraber görüşlerini almıştık. Ondan mezun olan arkadaşlarım da var, acil tıp uzmanı. Onlar da çok memnundu zaten ultrason konusunda. Onun katkısında olması daha güzel.
Peki kursun akreditasyonu ile ilgili birkaç kelime alabilir miyiz sizden?
Bence yabancı hocaların anlatmasıyla, Erol Hoca'nın da bütünleşmesiyle her şey güzel. Bir şey duydum ben sabah, case'lerle gidecekmiş. Mayıs'ta da herhalde yine bir hazırlık olacakmış. Vaka üzerinden gidecekmiş. O daha hareketli olabilir tabii.
O yeni planımız. Şimdilik sürprizi kaçmasın, söylemeyelim. Bundan sonraki projemiz o. Çok teşekkür ediyoruz. Kursumuza tekrar hoş geldiniz.
Ben de teşekkür ederim. Emeği geçen herkese teşekkür ederim.
Derneğimiz Yönetim Kurulu üyesi ve Sono School Başkanı Profesör Doktor Erol Ünlüer'le beraberiz. Hocam tebrikler. İkinci uluslararası kursumuzu, Avrupa Akredite kursumuzu tamamladık. Bu kursla ilgili düşüncelerinizi, duygularınızı almak istiyoruz.
Bir kere hakikaten çok mutluyum. Bu ikincisi oldu İstanbul'da senelik akredite kurslarımızın. Sertifikanın önemi gittikçe daha çok anlaşılır hale geldi. Çok büyük talep vardı ve 2 ay öncesinden bizler bu katılımı kapatmak zorunda kaldık. Netice itibariyle her sene daha çok katılımcı bu sertifikaya sahip olmak istiyor. Biz de verdiğimiz bilgileri, verdiğimiz bu bilimsel kursu bu güzel sertifikayla taşlandırmanın tabii ki gururunu yaşıyoruz. Ve Ben tabii tek değilim. Sağ tarafımda Akreditasyon Komitesi Başkanı mikrofonu tutan el olarak Arif Karagöz. Sol tarafımda Hindistan'ın ultrason yüzü Doktor Fabit Muaden var. Yani bunların hepsi bizim takımımız. Gördüğünüz gibi hem kursu biz veriyoruz hem de röportajı kendi kendimize yapıyoruz. Bu da güzel bir şey. Çok mutluyuz. Katılımcılarımızla beraber çok hoş zamanlar yaşadık. Umuyorum diğer bizim gibi bilimsel düşünen insanlar bizi takip edip bizi de taklit ederler diye düşünüyorum. Yani çünkü bu da bir rekabet isteyen bir şey. Umarım daha iyisini kendileri yaparlar ama biz de daha iyi şeyler yapacağımızın müjdesini şimdiden verelim. Daha seneye bizi çok daha güzel şekilde göreceksiniz. I want some few words from Dr. Fabit about the course also. What do you think about this course?
I'm Dr. Fabit from India. I think this is one of the best course. I love traveling to Turkey to do this teaching in Sono School. Sono School is the best for ultrasound courses. And I think we are doing great. In last 3 years we have grown a lot and the feedback from the delegates are excellent. So I hope we have partnership and we'll continue the same partnership with India and Turkey and other countries as well. Thank you, Errol.
Thank you.
And thank you, Sono School.
Thank you very much, Hannah, for this very nice invitation. It's a privilege for me to be the first speaker of this huge Congress, and I think that what you did in this session is to address the importance of invasive technology as a new opportunity to increase the powerful of emergency medicine worldwide. I really am happy to address this topic. And this topic is coming as the need, and we will see during my presentation, to work together. Not only emergency physicians, but radiologists, interventional cardiologists, to produce more evidence and publications, as we did into the great network, worldwide academic research organization that is with Watson worldwide trying to increase the powerful of publication in our group. And I really appreciate that you put in the backs many journals, because this is the future of emergency medicine, to produce evidence. So let's go now and see, after my disclosure, what are really the need for technology support after clinical evaluation. Before starting my talk, let me tell you that no technology can support a bad emergency physician, because the best technology emergency physician has is his holistic opportunity to visit the patients and make clinical decisions. By the way, in the last 25 years, we saw an important increase in quality of laboratory testing, especially biomarkers in acute disease and point-of-care biomarkers, but also technology of imaging. So laboratory testing and imaging are going to be the big revolutions in our job to increase the quality of our medical effort and, most importantly, increase patients' outcome. When you talk about imaging, for sure you know that ultrasound are totally changing our ability. Every emergency physician now are able to perform ultrasound, and I'm very proud that we were the people that teach cardiology on how to use chest ultrasound to detect many diseases they were not able to do. But nevertheless, besides the ultrasound that are growing impact, there are other technologies such as point of care, looking at the computer-assisted imaging, but last but not least, the angiography. Angiography is really important, and I think it's something that can really improve our knowledge and also quality of health delivery system. But of course, the issue here that angiography need a cath lab, or let's say radiology interventional box that should be as much as possible close to the emergency room. So this is the first example. 250 years ago in my regional city, Naples, these researchers input some substance into the vessels of humans. And these skeletons are still there in Naples, one man and one woman. And you see, he put these injections, but unfortunately, patients died. But luckily now, we have many different radio contrast possibilities that are able, thanks to invasive medical imaging technology, to use this iodinated contrast material to visualize the lumen of blood vessels. And this is very important because thanks to the angiography, now we can have very clear opportunity to see the brain, the neck, the aorta, the chest, the gastrointestinal tract, and so on. But what is important, not to abuse the technology, but to make the right decision. First of all, now blood vessels should be evaluated also with non-invasive technologies such as ultrasound, echo Doppler, TC scan, and magnetic resonance imaging. Nevertheless, although these new non-invasive technologies are going to be every day much more precise, we still need angiography, catheter-based, in the cases you need immediately decision-making to transfer the patient to surgeon, or last but not least, to have access to intervention radiology procedures that can impact the length of stay of our patients in the emergency room, and also to reduce the length of stay in the hospital and the costs related. So this is the way you have to think about how angiography can really increase our emergency department job every day. So I have one question for all of you. How many of you today have an angiography service available 24 hours, 7 days in your emergency department? Please raise your hand. Not so bad, 15%. Okay, let's see if the other 85% could be convinced at the end of my talk to try to insist to have an angiography box in their emergency department. So, and I think this is coming to the fact there are so many acute diseases that are elencated here, such as acute myocardial infarction, multiple pulmonary embolism, trauma, that can benefit having an angiography area into the emergency department. First of all, let me address my special topic, acute coronary syndrome. We know that time is myocardium, so you really want to start as soon as possible in the emergency department to reopening the vessels in the case of MI. These recently published 2019 guidelines on how and when to perform angiography in acute coronary syndrome is very clear that in the case of elevated ST myocardial infarction that is within 12 hours, you should do evidence 1A, in all these cases, a PTCA. And then that is a delay opportunity, still evidence 1A, if you have no cath lab available, that you can do fibrinolysis. So in any way, you are going to perform in many patients as soon as possible angiography, coronary angiography, and then opening the vessels. This is a cartoon that I would like to take in mind, but I'm sure everyone in the audience is aware. In the case that you are able to make EKG in 10 minutes, and you are going to refer an hospital where the cath lab is not available, you have two choices. If you are the STEMI, in between 120 minutes, in that case, you can refer for 90 minutes, transfer the patients. Alternatively, if you have 2 hours that the STEMI is started, you can start fibrinolysis there, and then you can reperform in 10 minutes, transferring the patients. But if you have the cath lab, angiography, and the coronary PTCA available, you should do this in less than 60 minutes. I think it's very important to save as much as possible lives in acute coronary syndrome in our patients. What about if I have a patient with not ST myocardial infarction elevation? In this case, there is the opportunity, if the patient is very high risk, also to go for invasive procedures if the patient is hemodynamic instability, if there is life-threatening arrhythmias, and also acute heart failure. So still in these patients, you can do PTCA within 2 hours. So something that you could do there, because you are going to save and increase the number of lives in the emergency department. So let's move now. Another important frequent reason of patients coming, pulmonary embolism. In this consensus statement for multidisciplinary physicians, it's very clear that in the case there is a big embolus that is very close, massive embolus, very close to the original pulmonary artery, you should do catheter thrombolysis and removal of the thrombus. So it is very important also to consider in patients presented with the syncope, massive TC scan, pulmonary embolism, to do angiography and remove the clot. Now, what about the need also to look at the aorta during patients coming in? I'm sure experience with patients coming with chest pain, you are looking for acute myocardial infarction, the patients can have aortic dissection. So aortic dissection is really a situation where the emergency physician can have the need to make an aortoangiography. What the guidelines say that the most risk is the ascendant aneurysm and the dissection, where the patient should be immediately treated with the beta blockers. All these patients should have beta blockers and then transfer immediately to cardiosurgeon in order to make a decision. So aortic dissection is another really important situation when you need angiography to perform as soon as possible. Now, I'm sure also in your daily practice experience, you are managing with the patients coming in with acutely cool, painful leg, and in this case, you really are going to clinical put a suspicion of acute limb ischemia. In this case, you can perform a Doppler that is mandatory, and in the case of Doppler, you can have 3 possibilities. Assuming that you have no artery in the, let's say, pink area, sound, no vein sound, don't waste time. Ask the surgeon to make amputation on the leg. On the other side, in the green area of this cartoon, if you have presence of audible artery and veins, you are going to do angiography because you want opening the vessels that bring blood to the limb. So I think it's very important also in the acute limb ischemia after the clinical judgment and also non-invasive assessment to go for an angiography. Now, another important issue where the angiography is going to be increased, the role is a stroke, both ischemic and hemorrhagic stroke. In ischemic stroke, in the case of these 6 possibilities, pre-stroke MRS score between 0 to 1, causative occlusion of the internal carotid artery of MCA segment 1, age greater than 18 years, NAIHSS score greater than 6, aspect greater than 6, treatment of removal. The occlusion of the artery should be done after angiography, but in the case of the symptoms are greater than 6 hours, and you cannot do thrombolysis. But what is important, this leads to the need, like the recommendation, guidelines 2018 are going to put out the importance of a multidisciplinary team that is my auspicious in this conference. Opening the ceremony, I think is a very good opportunity for me to tell that we have to work all together in order to improve our skills and patients' treatment. And also it is important that angiography should be there in the case of ischemic stroke. And also it is important that you want to monitoring. So our job is not only to start appropriate treatment, but to monitoring patients' outcome and publications on the results. What about hemorrhagic stroke? There is no doubt there are a lot of situations where you can use clipping or culling of the hemorrhagic site after brain angiography, and then you can save the patients, especially if he has hemorrhage due on cerebral aneurysm. So it is very evident that so far we addressed the important possibility to check in the case of acute coronary syndrome, acute aortic disease, and acute stroke, the possibility to use angiography. Now, what about trauma? There is no doubt that looking at a lot of bleeding that are going to be not able to stop because of what you're doing with the medical treatment, you should need an angiography. In this case, what is important as an example of the very severe trauma is liver trauma. In the liver trauma, you should consider two classifications. AAST, liver trauma classification, but also when you put together, let's say, the injury type, the grade, the injury description, you should also put one important, very, very important evaluation, the hemodynamic instability. So I would like to emphasize this important clinical judgment of hemodynamic instability, because if hemodynamic instability is present in the case of a liver trauma, you can go a very severe lesion to WHS, ESIV, and go to operating room immediately after an angiography. So there is no doubt that also in the case of liver trauma, you can have a lot of possibilities. And I think that this is going to be of a great importance also in other trauma. Now, you know, our neurosurgeons are very good and with the intervention radiology to make spinal arteriography. And in the case of spinal trauma, they are able also to make embolization of very small vessels of our spinal doors and resolve the issue. So now let's move to the last but very important topic, that is acute gastrointestinal bleeding. I'm sure you are fighting every day with a lot of geriatric people coming in, taking anticoagulants, even decumarol, or new anticoagulants that have a lot of bleeding, especially if they take decumarol because they are able to control INR. So there is a very important, again, the need for the emergency physician to assess the hemodynamic instability and then immediately to perform an upper endoscopy. If the endoscopy is negative, you can go to check the colonoscopy, but if it is not possible to be prepared because you need colonoscopy, you need preparation, then you can go immediately for angiography. That is really something that emphasizes the need to have angiography area where you can do a lot of important setting decision making. Now, what about embolization? I am sure this has been during the last 10 years, the revolution in stopping bleeding. And you can see from these data coming from registry, you can see that in trauma, the overall success of embolization is around 100%. Amazing. Amazing. You can solve the issue in many trauma, and also in the case of gastrointestinal bleeding, both from upper or lower sides of the enterical system, you can have embolization that are going to save lives. So it's not only a problem of hemorrhagic situation, but also of ischemic. Acute mesenteric ischemia is another important situation where, again, starting with the clinical suspicion, you are going to look about the possibility to have acute mesenteric ischemia and then to do CT scan and angiography. And also, in this case, you can have arterial thrombus that you can find, and then you can open the vessel. So I think it's very, very important to make important decision where to move or not from non-invasive clinical assessment to angiography. It seems to me there is a lot of room to improve and to need of angiography in acute setting. Let's talk about the contraindications. The last 2 minutes of my talk, I will address this important situation. Let me tell you that there are not really many contraindications in the case of need to perform angiography. You just need to make sure the blood pressure is quite controlled. You don't want to make sure that there is a renal insufficiency, so that the iodide contrast material is not going to deteriorate the damage, the function of the kidney. But thanks to the new quality of a new product, this issue is going to be very low. So in the future, my friends, we are going to have a lot of people, especially because life expectancy is worldwide increasing. And for the reason of that, we should, and also geriatric people, they have a lot of bleeding.
we should really think about to increase our angiography performance into the emergency room. And these are my conclusions. After an initial clinical and non-invasive technology evaluation, I put this in red because it's the starting point. Please don't go immediately to angiography unless you have not made clinical judgment. In any case, it represents angiography a cornerstone in various clinical situations in the emergency department. It is also important because you are going to reduce the time of saving life and in hospital length of stay, so you can also save a cost. And in the future, I think it's very important that we are going to increase working together in the skills of angiography. But what do we need? We need research, data publishing, because like this consensus statement on academic emergency medicine pointed out a couple of years ago, in order to optimizing emergency department, the diagnostic imaging has the potential to improve the quality, safety, and outcome in the emergency department. Because also don't forget the radiation are potentially dangerous for your patients. You really want to vote for the right patient, and we need the data. So my final auspice will be to produce more data in this setting. And thank you again for giving my talk. So just the last 20 seconds, how many of you now are happy to have an angiography service next day in your emergency department? Yeah, I think it's increasing. I was expecting more, but that's okay. It's coming from 15% to 30%. Not bad, actually, without our auspicious. So, in any way, if you want really to contribute to our research, please come to Edinburgh or this biomarket, but last but not least, in San Diego, where we are working in implementing the geriatric emergency medicine, where I think angiography should be a big value. Thank you very much for your attention.
Thank you, Dr. De Soma. That was fantastic. At this time, are there any questions? I have a question for you.
Good.
That was a fantastic review of all the ways that we can use angiography in the emergency department in acute setting. It's not only diagnostic, but it's therapeutic as well. Do you see angiography at some point replacing the need for surgeons or surgery?
That is really the most important question. And I think, yes, this is the way we have to go, together. To produce evidence, if you saw last slides, I was making the evidence that we have to compare the value in any kind of innovations in emergency department that are two objectives, patient outcome and cost related. So if we are going, as you said, to demonstrate that we can reduce surgeon length of stay and mortality due to therapeutic angiography, we are going to get the goal. And this is possible only with emergency physician skills in this topic.
Now, how many people want angiography in their emergency department?
I want. Thank you.
Okay, I want to invite with my pleasure. He is chairman of from Stanford University, chairman of Emergency Medicine Department, and he's very popular in Turkey, if you remember from last Congress. And I think he has very excellent textbook of emergency medicine in United States. He will talk about retrograde intubation. Mr. Mahadevan, with my pleasure.
Good afternoon, everyone. How are you? Good, good. It's great to be here. Instead of retrograde intubation, I spoke with Dr. Chander about talking about video laryngoscopy, so I'm going to focus on that today. And first, oops. Okay, good. Let's try again now. There we go. Sorry. Okay. Just want to show you where I'm from. I'm from Stanford University, which is in the United States in California. So yesterday, approximately yesterday, 24 hours ago, my wife and I were there at that star right here. And now we're obviously in beautiful Antalya. And I just want to say this is my 5th visit to Turkey and love it here. I've been to Istanbul, Kayseri, Izmir, Konya, Çatalhöyük, and now this is my 2nd visit to Antalya, and I had the pleasure of attending a prior Congress, also getting to sing on stage. Hopefully I don't do that today and scare everyone away, and spend time with Bashar, which is always fantastic. In my talk today on video laryngoscopy, I'm going to define what it is. I'm going to talk about the different classes, the different kinds of video laryngoscopes, the advantages and disadvantages of this new device, and then most importantly, the current literature about video laryngoscopy and how it's maybe taking over how we approach airways. Very quickly, show of hands, how many of you are using video laryngoscopes in your department? Okay, fantastic. So quickly, with regards to the definition, video laryngoscopy is indirect laryngoscopy, which means you're not looking directly at the cords, that you're using a digital device, a digital laryngoscope, to show you the vocal cords in the glottis instead of line of sight. And generally, for what we need them for, acute intubations, we're inserting these devices intraorally. And why would we need to do this? Well, our goal is to see the glottis, and that hopefully will help us improve our success with intubation. And ultimately, we want fewer failed intubations. Obviously, we want to reduce our failure rate. So there are 3 big classes of video laryngoscopes. The first is the channeled video laryngoscope, where the endotracheal tube is part of the device or is inserted into the device, and this matches the anatomic curve of your pharynx and allows you to direct it towards the larynx. But unlike the other approaches where you are manipulating the endotracheal tube separately, this is all one device. So if you want to adjust where the endotracheal tube is, you have to adjust the device. And so the other issue with this, as you can see, is it's bulkier. It's larger than some of the other devices. And so if you have someone with a small mouth, it may be difficult to insert it. The next device I want to describe is something called a Macintosh-style video laryngoscope, where the technique is similar to what we're doing with direct laryngoscopy. And in fact, you could either use the video or do direct laryngoscopy. And for this reason, since everyone in the room can see what's going on and you can give advice, it's great for teaching and training institutions. And then finally, the glide scope or glide scope-like devices are acute angle blade video laryngoscopes, where they're really good at showing you the very anterior structures, but if it fails for whatever reason, you cannot convert to direct laryngoscopy where you can see the cord. So let's take a look at this. A glide scope-like device inserted into the pharynx, and then you're looking at the monitor, you're looking at the screen when you're inserting the endotracheal tube, and so you're looking at the monitor but performing the function in the patient's pharynx. So what are the advantages of this approach, video laryngoscopy? Well, first of all, we always struggle when we're doing direct laryngoscopy to line these 3 axes. There's the oral axis, the pharyngeal axis, and the laryngeal axis. And if you look at this diagram, what you can see is that it's impossible for us to see like this. we need to see, we have that line of sight. And so what we do is we try and get the patient into the sniffing position, as you can see here, and then by using the direct laryngoscopy and just raising their soft tissues, we achieve line of sight. And sometimes it can be very difficult, as you know, to see the glottis. And especially in patients like this. This is a trauma victim where you're not allowed to get the patient into the sniffing position because you're keeping them in the neutral position. And that makes it very difficult to align these axes. And in this particular case, the patient couldn't be intubated with the video or with the direct laryngoscopy. The other advantage in trauma patients specifically is the video laryngoscope can be inserted and manipulated in a way where you don't have to move the patient's head and potentially cause injury. Here's an example of a patient with an inferior anterior C2 fracture, but if we look at their cervical alignment, it's normal. So the spinal cord at this point is doing just fine. But what happens when you try to intubate the patient and you put them in the sniffing position? As you can see, this patient has a complete disruption of the ligaments holding the vertebral column together, and now the bones have moved and impacted potentially the area where the spinal cord is. So the last thing that we want to do is move the patient's vertebral column and potentially cause injury, which could happen, in theory, with direct laryngoscopy. And then finally, we're looking at a very narrow, small area and trying to insert an endotracheal tube through that area. Well, what if we were able to enlarge it, make it easier to see? And also, more importantly, as a teaching physician, that not only I could see what was going on, but everybody in the room could have confidence that this was being done properly or that we could assist. So those are the advantages of video laryngoscopy. What are some disadvantages? Well, if there's secretions or blood and it gets on the end of the scope, potentially you wouldn't be able to see. Or if the device fails for some reason and that's the only way, that might be an issue. There are a lot of different kinds of devices, so you have to be familiar with all of them, and we're not sure which ones really are the best. And there's no real evidence to tell us this is the best one at this time. And the technique for insertion is different than what we're used to. And it may be more challenging, just in the same way that if I play video games with my son, he's going to beat me every time because I'm not used to playing video games. Learning how to do a new approach may be challenging because you're not doing it under direct visualization. You're holding the device and then trying to look at a screen and perform the technique. And a number of studies have shown that when you're doing it indirectly, it can be more challenging. So now let's go over 5 important studies that might change the way that you think about video laryngoscopy as part of emergency medicine. And the first one to bring a lot of sort of attention to this was this systematic review, Cochrane review, that was done in 2016. This Cochrane review wasn't specifically focused on emergency physicians or critical care physicians, but looking in general at comparing direct laryngoscopy to video laryngoscopy. So they looked at a lot of studies, 64, 7,000 plus adult patients, but again, mostly in the operating theater and not in emergency settings. They compared different kinds of video laryngoscopy to direct laryngoscopy using a Mac blade. And here are the primary findings of the study. There were fewer failed intubations with video laryngoscopy, and this was statistically significant. When dealing with difficult airways, there were fewer failed intubations with video laryngoscopy. And then when they compared the incidence of hypoxemia, it was similar between the two. So, major headlines, bottom line from this large Cochrane review: fewer failed intubations overall, fewer failed intubations when dealing with difficult airways. Next, we decided, since that was a focus on all comers and primarily the operating rooms or operating theaters, what about for those of us that practice outside of the operating room? Well, this systematic review and meta-analysis looked just at those places. So this was 32 studies with over 15,000 intubations. And you can see that there were about 6,300 video intubations and 8,700 direct laryngoscopic intubations. And these studies were outside of the operating theater, outside of the operating room. So they were in the pre-hospital setting. They were in the ICU. They were in the emergency department, places that we practice. And again, they use different kinds of video laryngoscopes as opposed to just one kind. And multiple kinds of providers. So there were beginners, there were experts, there were paramedics, there were emergency physicians, there were ICU doctors. So a whole mix of different kinds of providers. And what they were interested in is how often do you succeed intubating the patient the first time that you try. So let's take a look and see what they found. With regards to first pass intubation, there was no overall difference in this study between video laryngoscopy and direct laryngoscopy. However, if you were in the ICU, video laryngoscopes were better, but if you were in the emergency department or pre-hospital area, they were similar. What about the glide scope, which is one kind of video laryngoscope, and direct laryngoscopy? Well, they were similar. But when the CMAC, a specific kind of video laryngoscope that allows both direct and indirect laryngoscopy, was compared to direct laryngoscopy, it was better in terms of getting that first pass intubation. If you were a novice or a trainee, video laryngoscopes were better. But if you were experienced or a paramedic, it was the same. And then with video laryngoscopy, there were fewer esophageal intubations and more arterial hypotension. So what are the big takeaways from this study of non-operating theater, of emergency situations, ICUs, emergency departments, pre-hospital? Well, if you're in an ICU, video laryngoscopy was better. CMAC was better than direct laryngoscopy overall. And that if you were a novice or a trainee, that video laryngoscopy was better, and that there were fewer esophageal intubations. One of the themes that you're seeing here is that in many cases, in different facets, it's better, but it's never worse. And that's a very important thing as we move forward. Finally, I want to look at a study that it was a systematic review and another meta-analysis, but this time they looked at difficult airways and experienced providers. So most of you are experienced providers, and all of us that practice emergency medicine have had a difficult airway. And one of the things I think we can all tell you is, though we try and figure out who might have a difficult airway, sometimes it's very difficult to predict. And in this study, published in Anesthesia in 2015, of patients going to the operating room, the anesthetist could not predict a difficult intubation 93% of the time. They could not predict a difficult patient to mass ventilate 94% of the time, which tells us all of those tools and rules that we have don't work very well, and that any intubation could be a difficult intubation or a difficult airway. So in this study, which looked at experts and difficult airways, how did video laryngoscopy do? Well, it was better for first attempt at success, and you can see on average, when using a video laryngoscope, 95% of the time you were successful the first time versus 86% with direct laryngoscopy. And you got better views of the glottis and less trauma to the airway overall. So again, the take-homes, we're talking about experienced providers, difficult airways, and video laryngoscopy perform better. So it begs the question, this was an editorial that was in the British Journal of Anesthesia, about whether we should be using video laryngoscopy as the first approach all the time. And here's the analogy that they used. They basically said, how many of you still have a huge bulky cell phone like you did in 1995? None of us, right? We're all using some kind of iPhone or new phone equivalent, and none of us are using dial-up phones either. So as technology progresses, why are we relying on old technology when new technology is potentially superior. And they went one step further. They said it should be used on every intubation, and that we should record the video and put it in the medical record so that if the patient ever came back, they could review the video and determine if there was an airway problem or not. 2 more studies to review before I finish. This is a group of anesthesiologists that decided to replace all of their direct laryngoscopy with video laryngoscopy. So I'm going to show you what happened. First, they assessed all of their team about their attitudes towards video laryngoscopy. And then for 2 months, they removed all the MAC blades from their operating room and from the places where they worked, and they only had CMACs there, okay? Which CMACs where you can do video laryngoscopy and direct laryngoscopy if you needed to. And then they did serial assessments over a course of time to see what attitudes were by the anesthesiologists towards video laryngoscopy. So here's what they found. When they started, about a third, and a third either said we fully support only video laryngoscopes, or we have some reservations, or some people said they don't support it. At the end of the trial, the 2 months of just using video laryngoscopes, there were fewer people that didn't support, but it certainly didn't have unanimous support. 6 months later, you can see a lot more of the anesthesiologists supported it. And then 18 months later, uniformly, everybody in their department supported having only video laryngoscopy. And the reason that they said was they felt it was better for patient safety, team dynamics, human factors, quality of care, and quality of training. So they changed after being forced to use them for a period of time. Their attitudes totally changed. And then for many of us, it's the same. We're so used to direct laryngoscopy, we don't want to change, even though it might be good for us. And the last study I want to show you is one that's done in the pre-hospital setting, where they looked at a protocol where they used the CMAC, again, this video laryngoscope, and a bougie in all rapid sequence intubations. And so this was done in Finland, where for a period of time, they said you're going to use video laryngoscopy and a bougie, in particular it was a Frova introducer for all intubations. And then they compared that 22 months where they were doing that to the year before where you were able to do direct laryngoscopy. And here's what they found. Before using video laryngoscopy and the bougie, the first pass success rate was 85.7%. After being forced to use this protocol, using the bougie and the video laryngoscope, it increased to 98.2%. And think about it, intubating, doing RSI in a helicopter is a difficult airway situation. And here they went all the way up to 98%. And it begs the question, we always think of video laryngoscopy as a rescue device or a difficult airway device, but what if we used it routinely? What if we used difficult airway devices routinely? We can see that we would have an increased success rate, which we all want, and that, again, a bougie may be easier to pass with a video laryngoscope than an endotracheal tube. So a couple of takeaways from this study. So finally, what do we know? What's the bottom line? What can we say about video laryngoscopy? It improves the view of the glottis. It may improve first attempt intubation success rate. Remember the study I reviewed from Peters et al., 95% success rate with video laryngoscopy compared to 86% for direct laryngoscopy. The Cochrane review found that it may reduce the number of failed intubations. Again, fewer failed intubations when for overall and also when dealing with difficult airways. We know that it's already become part of our difficult airway algorithm, but it may be the primary approach for all intubations in the near future. And if you're using a device like I like, and I don't have any ties or affiliations with stores or the CMAC, but a device like CMAC, which allows you both direct and video laryngoscopy, is a device that might allow you to embrace the future without abandoning the past. And so those are my big takeaways about video laryngoscopy. And I want to thank you for your attention. Thank you very much.
Thank you very much, Dr. Madem, for fantastic presentation. Any comment or question? Yes, please.
First of all, welcome to Turkey and thank you for your presentation. I want to ask that I work in a hospital where approximately 1,000 patients apply per day. And I think that means that we manage disaster every day. And in my country, there are so many centers. While we are examining the cold or myalgia, on the other side, we may need to intubate the patients. And I think it's more difficult about us. What do you think about the practicality of this process in crowded emergency departments? Thank you.
Thank you for your question. I believe the question is that in settings where maybe you have less experienced providers, yet are crowded, what about having a device like this in those settings? And I think, you know, it's, as the studies pointed out, those who are less experienced with intubating actually showed the greatest benefit in first pass success. And so it probably behooves us, if you're intubating all the time, you might have some expertise, but if it's an infrequent procedure, having a video laryngoscope might be of benefit, especially if you're doing it infrequently. But the other study I showed also revealed that even in experienced hands, it's hard to know when we're going to encounter a difficult airway. So rather than take a chance, my feeling is that we are progressing towards where we'll be using this exclusively, and that direct laryngoscopy will be something of the past.
Okay, thank you very much. Any another question?
Yeah, here, yeah. It's okay.
Okay.
No, Basar, I have a question.
Okay.
Thank you very much for this nice presentation. And it's clear we have the evidence for using this kind of tools. My question is, do you have information about the cost? You know, if you compare CMAC to the direct, laryngoscopy, this is very important, for different countries in the world.
So the question was a very good one, which is it fiscally responsible to replace a device that may be working with something that may be more expensive? There's two ways of looking at it. If you already are adding a device like a CMAC as a rescue device, then you're already purchasing it anyway in addition to the direct laryngoscopes. And the other one is more philosophical, which is that if your complication rate goes down and you have one less patient who has anoxia as a result of a difficult airway encounter, and the hospital isn't sued or doesn't lose money as a result, or the family doesn't lose money as a result, then that could justify, that cost savings from fewer complications could easily justify the cost difference between a laryngoscope and a video laryngoscope.
Okay, thank you very much. Last question, please. Last question. Yes.
Thank you very much for your presentation. I will ask, you said that some kind of video laryngoscopy is better than direct laryngoscopy in difficult intubation, but was it expected difficult intubation or unexpected, or was it well-designed criteria?
In the study that I presented, it was anesthesiologists who predicted a difficult airway based on patient characteristics or prior knowledge, and in that case video laryngoscopy was more effective, even though they were experienced. But there was one study that I presented also that just shows we are not good at figuring out who is going to be a difficult intubation or difficult mask ventilation. And that's the problem. If we could just look at them and say, oh, you've got a beard or you've got a short neck, you're going to be a problem. But we've all encountered somebody that we're really worried about, and then we go in and it's an easy intubation. And we've also had patients where we say, oh, they've got a long neck, it's going to be fine, and then you go to try and intubate, and it's much more challenging. And so it's just, we don't have good tools. And we should just, basically, my feeling is approach every patient like they're going to be a difficult intubation. Thank you again for your question, and thank you for your attention. Thank you. Thank you.
Next speaker. It's a very important topic for emergency medicine, new topic. Reboa in ED. Dr. Yosuke Matsumura from Japan. Thank you.
肺結性 E 軍団ベニムアディムヨスケ松村ジャポニアダンゲティムI'm an emergency medicine physician, and I also cover the ICU. And my another subspecialization is endovascular therapy. I cover the interventional radiology and, of course, REBOR. And I also love to perform ECMO. So I am very interested to be here. Thank you for having me. So here's my disclosure. So let me introduce some REBOR practice in Japan. So this is the procedure video. The first thing you need to do is get the access. The access as the common femoral artery. You need to puncture between inguinal ligament and bifurcation. Of course, you should use ultrasound routinely. You can see the bifurcation directly. And you advance the guide wire to the aorta. Then remove the needle and insert the arterial sheath over the guide wire. Then you can put the REBOR over the guide wire. In this setting, the balloon is going up to zone 1. And next step, you need to exchange the guide wire for a stiff wire. This stiff wire will strengthen the shaft of the catheter. Then, then you can inflate the balloon. So by the way, the term REBOR was published in Journal of Trauma in 2011. But in Japan, we start to use REBOR catheter in 1998. So we have a very long history. Oh, sorry. But unfortunately, we didn't publish a lot of research paper in this field. 2003, 2009, 2015. Sorry about such long silence. Only small case series were published from Japan until 2015. But in this year, one case series was published in Journal of Trauma. The title is Safety and Feasibility. But I need to give a question to this paper because they reported the rate of lower limb amputation at over 20%. Surprising number. Next year, another paper was published. This is a database analysis using a propensity score match analysis. And they reported higher in-hospital mortality in REBOR group. This is negative data from Japan. A similar study was published very recently in JAMA surgery from the United States. This is again propensity score matching. And they reported higher rate of AKI, amputation, and high 24-hour mortality in REBOR group. So lower limb amputation. These two studies, the research period was before 7 French Ribot device. In the United States, they used to use 12 French, and in Japan, we used to use 10 French catheter. But now, we have 7 French small profile Ribot catheter. So probably this problem can be solved with such small profile catheter. This is our publication, so we demonstrated the fewer complications in small sheaths. We didn't require any fasciotomy, amputation, or PTA. But what about higher mortality? How should we use Ribot? One possible answer is here, algorithm. This is the classical algorithm suggested by Shock Trauma Center in the United States. And this is another algorithm from the Denver. This is another algorithm presented in the Western Trauma Association. How many Ribot algorithms do we have to learn? I hate to memorize many things. I believe to learn trauma strategy is more important to learn algorithm. So this is the summary of today's my talk. The first is thoracotomy plus Ribot can be the good solution in a critically ill patient. And second is early access, undelayed but short occlusion. These are the key issues for the successful management of Ribot. And third, I'm going to mention the education and research briefly. So let me introduce our recent case. 17-year-old boy, he fell from 11th story of the building. Actually, he jumped from the building. He collapsed 5 minutes before arrival, and CPR was initiated by the EMT. So first, we performed resuscitative thoracotomy and LD cross clamp. And he was resuscitated after 8 minutes of the CPR, and chest X-ray didn't show any significant injury. And the fast exam was negative, and pelvis showed the fracture. So I identified the cause of the shock was here. So we got bilateral arterial access and the large venous access, and the massive transfusion was initiated. Then the fast turned positive at right upper quadrant. So I decided to go to laparotomy first. Can you see this picture? Before going to the operating room, we converted thoracotomy to zone 1 Ribot. And the patient was transported with partial Ribot. And in the operation room, we could defrayate the Ribot within 20 minutes, and the surgeon found a liver injury. But it was not so severe, and fortunately, no other organ injury was found. Instead, retroperitoneal hematoma was expanding rapidly, and so the surgeon simply performed perihepatic packing, and abdomen was left open. And next, this is my turn. I embolized bilateral internal iliac artery approximately within 10 minutes. And now, we didn't see an apparent extravasation in this patient. Now we scanned the patient, but we found a chest wall bleeding. So we reclosed the chest wall in the ICU. So first, the thoracotomy plus Ribot. So we performed thoracotomy first, then converted Ribot. So this is a comparison between thoracotomy and Ribot. The thoracotomy is absolutely more speedy and definite, but we need to make new chest wound, and sometimes the chest wall bleeding is significant, and thoracotomy may induce hypothermia. The Ribot is less invasive and adjustable, but we need to puncture the common femoral artery. Sometimes this is troublesome, and the patient has a leg ischemia. So this, in Japanese educational course, we suggest this strategy. If the patient is impending cardiac arrest, or if the patient doesn't have arterial access, don't hesitate to do thoracotomy. But if the patient is shocked but not cardiac arrest, and the patient has the arterial access considered REBOR. This is a comparison between thoracotomy versus REBOR. So one study showed the benefit in REBOR and the other did not. This is a study from the United States. They concluded REBOR has a benefit in selected patient. What is a select patient? It means no CPR but hypotension at arrival. But do we have to compare thoracotomy versus REBOR? My answer is no. We can perform these two aortic occlusion methods in one patient. I know thoracotomy is not strongly recommended in pulseless blunt trauma patient. And of the 106 trauma REBOR patients, we experienced 30 thoracotomy plus REBOR population. And of these, 6 patients survived. And interestingly, all of them received CPR before REBOR. It means thoracotomy plus REBOR may give a chance even in a pulseless blunt trauma patient. Theoretically speaking, conversion prevents hypothermia, and closing the chest may prevent chest wall bleeding. The second, the early access. So we obtained arterial access simultaneously with a thoracotomy. So we got bilateral arterial access. In the top stent textbook, this was published by the EVTM Society, the guys with the Swedish or European guys, and we suggested AABCDE concept. What is AA? Artery, airway and access come first. Of course, there are some disadvantages in arterial access, such as vascular injury or hematoma, but delayed access can lead to more significant catastrophe, like less palpable cardiac arrest, more hematoma. So I investigated the benefit in arterial access in REBOR patient. So I analyzed 109 REBOR patients, and naturally, in non-survivors, presented a higher ISS and lower SBP, pre-occlusion, lower SBP, and longer total duration of occlusion. And non-survivor showed longer arrival to access. The survivor got access earlier. So I performed a binary logistic regression analysis, and the result showed arrival access time was significantly associated with the survival outcome. The odds ratio of 0.989 seems small number, but this is every minute. So if the access delayed 10 minutes, the patient's survival rate decreased 10%. This is a big number. And then I defined the cutoff value about 20 minutes. In early access group, they showed significantly better survival curve. So I believe there is a benefit of early access in REBOR patient. And next, the undelayed but short occlusion. We could deflate the balloon within 20 minutes. So how long can we occlude? This question is very good but difficult to answer. So I couldn't answer this in a good answer, but the survivor shows the pre-occlusion pressure of 70, and survivor shows total duration of occlusion of 30 minutes. So this is not the cutoff value, but undelayed but shorter occlusion can be will lead the successful management. So there is a different trauma system in the world. So let's compare Japan, Turkey, and the United States. So I found a lot of similarity between Japan and Turkey. For example, I'm in emergency medicine, and we are responsible for the resuscitation of the patient. But in the United States, the statement recommend acute care surgeon or vascular surgeon should perform the rebore. But in Japan, we, emergency medicine, perform rebore. So in my mind, resuscitation must not be delayed, so first responder should perform rebore. So in this country, this is you should perform rebore. Because emergency medicine, we have the good friend, ultrasound. We can see the bifurcation of the common femoral artery, and we can see the guide wire in the aorta. This can lead to safe procedure. And next, the patient population and the mechanism of injury. We have a lot of geriatric population, so we often have the coagulopathy, and we often have such tortuous aorta. So you may encounter such difficult patient. So that is why education is very important. So regarding the education, the endovascular workshop is the key education, key occasion. And there are several endovascular workshops in the world. We start the DIRECT Society. DIRECT means Diagnostic and Interventional Radiology in Emergency and Critical Care and Trauma. We start a workshop in 2011, and we create a program including such a simulation or a 3D vessel model. Sometimes we use live animals, sometimes we use cadaver. This is zone 1 occlusion, this is a zone 3 occlusion. And in the United States, from 2013, the BEST course, the Basic Endovascular Skills for Trauma, started in the US. The shock trauma is the center for the BEST course, and I've been working as a visiting researcher here, so I supported the course. And from 2014, in Sweden, the EVTM, the Endovascular Resuscitation and Trauma Management workshop,